Hello, welcome to this PSPA webinar, which is part of our Ask the Expert webinar series. Today, I'm joined by Joanna Wallace, who is a specialist speech and language therapist. Joanna's part of the Atypical Parkinson's multidisciplinary team at the Queen Elizabeth University Hospital in Glasgow. Our focus today is on some common questions which are asked about PSP and CBD and how these conditions can impact speech and swallow. Hi, Joanna, nice to see you.
Hi Jules, how are you?
I'm fine, thank you. Right, before we go into the questions and launch ourselves in, it'd be really great if we can start our chat with you just giving us a sort of brief overview of the role of the speech and language therapist in supporting people living with PSP and CBD.
So speech and language therapy has a really integral part in the MDT. We initially sit in capacity as offering assessment and advice to patients coming along to the clinic in Glasgow. We help to manage difficulties relating to speech, language and swallowing. For patients who then complete assessment and require a period of therapy, there's loads of different things we do to help manage each of those conditions. So with speech problems, it might be an episode of therapy to help with any changes in the patient's speech. It might be that we work with colleagues relating to communication aids if someone's needing real support with their communication. We also help support patients with language problems. So that's perhaps where there's more difficulties in the thinking of the words to say, putting together the sentences. And we work really closely with our colleagues in occupational therapy and also in neuropsychology in the assessment and management of those problems. Swallowing is a really big one. So we work alongside our dietetic colleagues, medics and nurses as well in managing perhaps changes to someone's saliva management, but also in their ability to take their food and drink. It might be that we have to modify their food and drinks, and we'll probably come and chat about that a bit later. Mm-hmm. It might be that we're just looking at using different cutlery, different cups, or altering someone's positioning, etc. We also have a really big role in working with patients' carers and families around providing advice and education in speech and swallowing problems. And we also carry out training sessions to other members of the MDT, perhaps colleagues like yourself, Jules, mm-hmm. Also wider carers and health professionals. So we have a huge role to play, and it's brilliant to be part of the MDT in Glasgow.
Lovely. That was a great overview. I really like that. That was really clear. Thanks, Joanna. That was brilliant. Right, we'll launch into the questions if you're ready. Some of these questions have come from carers or people living with the condition. Some have come from other health and social care professionals, and a couple of sort of common questions that we get asked on the helpline quite a lot. So it's a bit of a range for you. So we'll start with one that's come from somebody who's caring for their mother. So it says, my mother has pureed food. She's eating very small amounts now, and her thickened drinks are given via a spoon. She'd like to have some idea of what to expect as far as a time frame of this decline, as she's chosen not to have PEG. So I suppose she's looking at what's going to happen now.
Yeah. So often the management of swallowing problems as time progresses tends to be through modifying diets, and your mum's on a puree diet, which is pretty modified. You mentioned as well she's been given food via a teaspoon, so I would imagine perhaps the amount that her mum is managing to take is maybe limited here. It's quite a tricky question to answer there without knowing a few other details, but certainly there's a few things I would probably have a wee think about that might help to guide where your mum is in her disease progression. The first thing I'd be thinking about is maybe fatigue with your mum, and if she's taking very small amounts, often the advice is around, rather than thinking of your 3 traditional meals a day, thinking about small and often, so that if at breakfast time perhaps she doesn't manage a huge amount or she's too fatigued, it's to think about trying in the next hour rather than wait for lunch. So think about how how much your mum's taking throughout the day, take the pressure off, 3 big meals a day and drop down to small and often, and that can help to try and maintain your mum's calorie intake throughout the day. The other thing I'd be having a wee think about is how well your mum's able to maintain her posture when she's eating and drinking as well. If she's maybe perhaps in her bed and is fed in bed, making sure that she is upright and alert. Often if that becomes challenging or difficult for your mum to maintain her posture, that's maybe more a sign of the disease progressing as well. The other thing you've probably spoken to your own speech and language therapist about is how your mum manages her secretions. So that's her own saliva in the mouth, and also any secretions that you might be aware of in the throat, any gurgliness. Often if someone has swallowing problems like your mum, it might be that she also is having some difficulties managing her secretions. Could well be this is already in place, but make sure you do chat with your speech therapist and wider team to get some support just to help manage that, to make sure your mum is as settled and able to take oral intake as she can be. The final wee thing, again, you're probably doing this already, is looking at the calorie intake. Would your mum benefit from supplements? Perhaps you've decided not to pursue that if PEG isn't part of the management plan there. But I think if your mum's been managed by a speech therapist and you've got that advice around puree diet and thickener, hopefully all those other things I've discussed are in place to help manage how she's doing, but probably a wee bit difficult to give exact guidance without knowing your mum on exactly where she is on the disease progression there. But I hope that helps.
Lovely. That's great, Joanna. I think we're going to come on to some questions about PEG, which was a difficult subject, isn't it? And I suppose it's very difficult, as you say, without having a full picture, to be able to gauge what's going to happen for somebody, because I must be right in thinking that some people can exist for quite a long time on very small amounts of food, can't they?
Yeah, absolutely. I think because it tends to be a gradual progression for people, that the body adapts to that, and people are taking small and often amounts as opposed to the regular 3 meals a day. So I think you're right that often it's really hard to predict for that reason.
Absolutely. Great. So still on food and modifying diet here. So do you have any advice or suggestions about what people should do about thickeners? Like somebody suggested Nutillis here. I know for want of saying it, there are other products on the market. It could sort of explain the role of thickeners for people.
Yeah, absolutely. So Nutillis is the name of the thickener that we, certainly NHS Scotland, uses. There might be other brands used elsewhere. They all do the same job, which is it's a powder that's added to fluid and it changes the thickness of the drinks. The theory with thickeners are that it thickens the drink, so that when someone with swallowing problems takes the drink, they then have more time, more chance to coordinate the swallow, and less chance of things going down the wrong way, going down into the airway rather than the tummy. So that's the theory with thickener. It's a real, quite a personal choice actually. So personal choice for patients, but also depending exactly what swallow problems someone's having. There's definitely pros and cons to thickener, and it's often led by the patient's choice. The benefits are it can help to keep the airway safe. It helps to stop aspiration. It can really help to reduce distress around coughing and choking as well. And that's a huge one if we can alter someone's quality of life. So it's really excellent there. For some people, they do find it less palatable. Mm-hmm. It shouldn't change the taste, but it does feel different in someone's mouth. And for some people, that quality of life is a huge thing. And perhaps for that reason, they'll say, I'm not sure on thickener, what's the other options? And And we would look at things like different cups, perhaps different maneuvers to swallow. I would say certainly within the PSP and CBD population, thickener generally is quite commonly used as swallow problems do progress, but it's very much an individual decision. If the person who asked this question is into Google, if you Google, you know, benefits and downsides to thickener, you'll be able to read a lot on both sides there. So I would say definitely has a role, definitely can have a positive impact, but it's very much patient dependent and patient decision, and we'll work with them on that.
Brilliant, thank you, excellent. So on to PEG, which I suppose is discussing thickener leads on to discussing PEG, doesn't it? We've got two questions in one here. So one is, you know, is it the case that it's best to get a PEG well in advance of being needed, and is it always necessary? Two parts there.
Okay. It's a brilliant question, and I think it comes up all the time in the clinic and in managing patients. Again, maybe a slightly hazy answer, but it's very much a case by case and patient-centered decision. Certainly the discussion around the timing, the advice for any neurodegenerative condition like PSP and CBD is always to have a discussion around PEG as early as is suitable for that patient. And the reason for that being it allows the patient and the carer to have a really unpressurized and really well-informed discussion when perhaps the swallowing isn't impaired, and that they've got the headspace to really think about what to do. So absolutely the advice would be early discussion is what's key here. And again, that will be different from patient to patient. It's often initiated by the nurse or the medic's consultation. It might be with ourselves if swallowing problems start to come up. In terms of, is it needed, is it not? Again, it's really patient-centered. There are pros and cons. Again, similar to my answer for the thickener, it can really help if someone has swallowing problems that are deteriorating and are perhaps distressed by choking or coughing with that, and that we're struggling to manage that through diet modification. Then PEG and use of alternative feeding can really help to reduce distress if that exists. There is some evidence that says quality of life can really be improved with a PEG, but it doesn't necessarily extend the life. There can be risks associated with the procedure itself, and thereafter there can be some issues with infection. So it's not without its issues, and that has to be weighed up by the patient and the team. But absolutely, a lot of our patients do proceed with PEG. It can be very, very helpful to help manage when the swallow is declining. Often we have patients who are still having oral intake, but are also supplemented with PEG feeding. And that helps to really take the pressure off the oral route, particularly if fatigue is starting to become a problem. So certainly in my experience, it's patient-led, patient-centered, but absolutely there is a role, and I think quality of life is a really important decision point when it comes to PEG.
Lovely, thank you. And I know I've come across people, and we've spoken to them on the helpline, who are not using PEG for their nutrition, but they're using it as a route to take their medication more safely. So I suppose it's about your role in gently explaining that over a period of time. And again, those conversations, provided they're early enough, are able to be had, and people aren't frightened into making that decision too quickly.
Absolutely. And it's that window of opportunity as well. It's a procedure that involves being in hospital, that if the patient's well enough, we want that to be early on as well. Yeah.
Excellent. Thank you. Excellent. Really good answer there. Okay, so can you explain or to people what the purposes of a video fluoroscopy? Have I said that right? Somebody's asked,
yes.
why do they need one?
Okay, so video fluoroscopy, short abbreviation is a VF, is a swallow X-ray, and it's generally recommended by your speech therapist. It will be done in the X-ray department of your local hospital, and it's a really quick and simple procedure. There's no tubes or cameras at all. You're sitting beside the X-ray screen. And similar to the traditional swallow assessment, you'll be given some food and drink, the difference being that it's mixed with some barium. And it allows us to see how your swallow is at the oral stage, which is in the mouth, and also the pharyngeal stage, which is the top part of your throat. Why you might need one is possibly because your speech therapist has some questions that they can't quite answer from their bedside assessment. More often than not, VF is really helpful to confirm or otherwise if you're possibly aspirating, especially if that aspiration is what's called silent. So if you're swallowing and perhaps having chest infections, but you're maybe not coughing when you drink, it could well be that silent aspiration is happening, so where it's going to the airway without any overt sign. So a VF can be really helpful to show on the screen whether you are aspirating or not. So it's a really helpful X-ray. As I say, it's really quick, a really helpful procedure, but often it is because your speech therapist needs some additional information. It can also be really helpful to maybe monitor someone's disease progression. Obviously, we need to be mindful of it as an X-ray and radiation, so we don't want to repeat them too often, but sometimes they are used to help monitor swallow progression. So there might be an occasion where it's repeated in 4 months' time, 6 months' time, and that helps us to see whether things are changing and what those changes are. So yeah, I think that's probably why you've been advised to get one.
Excellent. I was going to say, is it the sort of thing that maybe is done more than once? You've gone ahead with that. So that's brilliant. Absolutely excellent. Yeah, I think often what happens is people are maybe suggested procedures or tests, and you get it suggested, but when it's about yourself, it sort of goes in one ear and out the other, doesn't it? And you need it explaining a little bit further. So that was a really clear explanation. Thank you. Okay, we're going to go on to speech now. We'll leave swallow for a moment and move on to speech. Equally as important. So can you suggest some ways in which a person can communicate once their speech deteriorates in fluency and volume, which is at different stages for different people with these conditions, isn't it?
Absolutely, yeah. And this is a speech therapist bread and butter. This is what we do well. So with, you mentioned there's some fluency changes and some volume changes. That tends to be regards to PSP and CBD, often some of the common changes that we see, especially with the volume. We find that it can reduce in volume. People mention that they can't be understood quite so well, or they get asked for repetition. With the fluency, often that's the articulation isn't quite so clear. So they are really two common problems that we see with these conditions. The things that we could do to help would be your traditional speech therapy. And again, early intervention is the key here. So we'd want to see it early on. Often it's looking at things like your breath support, how you can use your breath differently to support your speech. Look at you phrasing things differently. Again, it might be managing your fatigue if that is a problem with your speech. We can also look at specific strategies to help manage your volume. There's loads of therapies here, one of which is called Lee Silverman voice therapy, LSVT. That's a really, really helpful treatment for volume issues. The other things as well, if someone's speech is perhaps changing quickly or that they are struggling to be understood, we can also look at something called AAC, which means augmentative and alternative communication. Now that could be as simple as someone writing down a word that's not been understood and holding it up to someone. It might be using gesture more than speech to help your message be across, or it could be looking at communication aids. So that might be a computer device to help support your speech. It could be word lists, it could be charts, it could be picture-based chart, anything that helps support your speech. Again, that might be something not necessarily to replace your speech, but if there are times where it's not so good, we can look at implementing AAC. Yeah, I think if definitely hope you're seeing a speech therapist, get asked to be referred. If not, there's loads can be done to help and support those changes there.
Okay, and would it be fair to say that when somebody gets referred to you as a speech and language therapist, let's say fairly early on in their disease progression, maybe following diagnosis, which is likely to happen if you're lucky enough to see a team where there's an MDT set up, would it be then that you would see them an initial assessment and then continue to see them, or would that be something that you would do as a one-off and then wait until things got worse? So how does it work?
It tends, with the clinic in Glasgow, it's the initial assessment, and it's then a mixture of patient concern, motivation, but also the assessment results. What does that show us? For some patients, all they need is perhaps advice on what to look out for. Perhaps things are very mild. So they would be for either discharged if they don't need anything, or generally followed up in however many months we thought was helpful. If someone is starting to show changes and is concerned, we would then want to see them for therapy, either within the clinic or refer them on to their local SLT. But absolutely, we'd want to be seeing everyone where speech is a concern or is starting to be a concern.
Absolutely, yeah, because obviously there's more input you can do the earlier somebody comes to you, isn't there, than waiting for it to get with. Do you think there's a place for voice banking?
I was asked this recently, actually, because often it's very commonly used in MND. Often a lot of the online voice banking tools are specific for motor neuron disease. But absolutely, it can also be used with PSP and CBD. The key with voice banking is early. So with voice banking, you're banking your own voice. It can then be added onto communication aids. But the key with voice banking is we want it to be done when there's perhaps just mild changes to the voice. The equipment that's used can do some repair to recording. So if someone has a mild speech change, they can repair that recording. But the more that someone's speech perhaps changes, there's only so much repair can be done, and your own voice wouldn't be suitable. So I would say absolutely voice banking's appropriate with this client group, but it would be that early intervention that would be the key there.
Absolutely, yes. I think it's I've worked with PSPA for 8 years, and we do voice banking, but it's only been in the last couple of years that I've noticed this increase in people wanting to access it, and I think it's coming from earlier referral to speech and language therapy is where that's coming from. Yeah,
and I think there's more awareness, isn't there? There's more people you're aware of using it, perhaps because there are more funding options as well. It's definitely more accessible, which is good.
Excellent. Lovely. You briefly touched on Lee Silverman, or LSVT, as people talk about. Can you just sort of explain a little bit about what that is?
Yeah, so Lee Silverman voice therapy is a really well evidenced voice treatment for patients with Parkinson's disease. It's the gold standard treatment that helps to improve volume and strength, with the treatment gains lasting for up to 2 years. It's a brilliant, brilliant therapy. There's loads of research into it as well. It's a wee bit, in terms of with patients with PSP and CBD, there's perhaps not quite so much evidence. There are a few wee studies that have started to come through looking specifically at using this therapy with those patient groups, and it can absolutely still be used as a therapy tool, but there's probably a few modifications that your therapist would have to look at. And there's a really good, for any speech therapist watching, there's a really good webinar on the LSVT website from 2017 that talks specifically about using LSVT with PSP and CBD patients. It's really good. And it talks about how the evidence does show improvement, and we can see improvements in volume, but what they found was the length of improvement, it doesn't last for quite so long.
Okay.
The other thing they mention as well is the voice quality. You might find voice quality isn't quite so good. The other thing with LSVT, one of the big things you do in therapy is loads and loads of feedback to the patient on how loud the voice is, how loud do they think they are. We use voice recordings, we use relatives and carers to help feedback as well. What this webinar spoke about as well is that the level of what we call calibration, so feedback to the patient. For PSP and CBD patients, your level of calibration needs to be much higher. Rather than doing your traditional follow-up, maybe 3-6 months after LSVT, it suggested doing follow-up every 2 months, again, just to try and avoid that decline. So yeah, there's not quite as much research, but there's this webinar on the LSVT website. There's also a study in 2015 that specifically looked at PSP and LSVT. And again, it highlighted, yeah, absolutely, it can be used, but the patient needs to be seen more regularly. The other thing it mentioned as well, so in LSVT, the aim is always to improve conversation, but you build up to that. You initially start with sounds, words, sentences, then conversation. What it mentioned for PSP was you need to be mindful of perhaps visual changes, and the tools that you're using in therapy might need to be more picture-based. Similarly, for patients with CBD who perhaps have language problems, again, you might need picture-based resources, so that's something to be mindful of. And they also said that it might be that your phrase and reading level is your maximum level that you would work on rather than conversation. So if there's speech therapists listening, they'll know what I mean. That's kind of week 3 in therapy, as opposed to your week 4 conversation level. So it's worth a wee look. There is some evidence online, but certainly what I tend to do with my patients with PSP who need this therapy is it's sometimes the intensity of LSVT that they can't cope with. So the intensity, it's 4 times a week for 4 weeks, so 16 sessions. That's a huge amount if you're already fatigued, if you have mobility issues. So I often find I'm having to do a modified LSVT, and we would call that loud therapy, perhaps seeing the patient twice a week for 4 weeks. The other thing is we've got the benefit of telehealth, and once your patients had their initial couple of appointments in clinic and they've got the hang of the therapy, we can then do telehealth. So that would be another key thing to look at to help manage fatigue there.
Brilliant. That's a great answer, because it's something that is more and more being asked. Those questions about LSVT. I think it was very much only Parkinson's for a long time, and it's interesting you saying that there are, although there's not a wealth, there are some studies to show the benefit, which is promising for people, and certainly people again who are able to get a diagnosis early in progression and referral fairly early in progression, that there are opportunities to extend their ability to communicate for longer.
Absolutely. As you said there, Jules, the early intervention is the key. And if you can get it, if this therapy is indicated early on, it would be to do it. And then you're likely to see more gains at that early stage that you can then top up. That's a brilliant thing with that therapy. You can do top-ups as often as needed. So yes, it is a brilliant therapy. And yeah, I was surprised as well, having a look how there's emerging research, but it's still not a huge amount out there.
Good. We'll have to champion the bit then. So leading on, when we just been talked, and I think you've touched on this at numerous points already, but somebody's saying, when should I refer a patient with PSP to speech and language therapy? Now, this question didn't come from a neurologist, it came from a GP.
Oh, okay, do it now.
Excuse me a minute, I've got to stop my phone ringing, and then we'll come back to what? I do apologise. I'll ask that question again. I'll start again. I've got to remember what I said. Okay. Right, yeah, are you ready? I'll start again. Okay, right, Joanna, we've already touched on this a little bit about when somebody should be referred to speech and language therapy. So I've got one question here which says, when should I refer a patient with PSP to speech and language therapy? And the question hasn't come from a neurologist, it's come from a GP. So it's a different route, but what would your best suggestion be here?
I think probably you will know the answer by now, but absolutely do it now. Early intervention is key. If you're thinking about it, that's a sign to do it. Even if there are mild problems, there might even be benefit to that patient from assessment, advice, might even be signposting to online resources for the patient, but absolutely early referral is welcomed by us.
Okay, that's excellent. In your experience, I'm assuming that as a speech and language therapist, that PSP and CBD are part of your training, part of your program, learning about them. Is it something that most adult speech and language therapists will have a knowledge of?
I would hope so. Certainly at university, absolutely Parkinson's disease is a core module in your adult neurological training. I think probably because over time that atypical Parkinsonism, what's the word, diagnosis and awareness has changed, then I think I would hope that is changing at the university level. I think because it's most adult SLTs should be aware of it. It might be that within your own SLT department or NHS trust that there's maybe only certain therapists that manage those patients. But certainly all adult SLTs are capable of assessing and managing these problems, but it might be that you are then seen by a more specialist therapist just to help with more specialist difficulties. Excellent, thank you. Yeah, I wasn't putting you on the spot. I think it's just important for everybody to realise, because I think people often think, well, they won't. We speak to people who've had a diagnosis and maybe haven't had the referral, and they'll say, well, why should I? What are they going to know? You know, we need to reassure people that everybody will be aware of it. Some people, like anything, have got a slightly more specialised knowledge, but obviously everybody's going to be aware of it. Absolutely. And I think the good thing is, because certainly the clinic in Glasgow, because we see patients from out with Glasgow, and often they then go back to their local therapists and therapy team, that we're happy to chat with those local therapists and local the wider team if they are looking for further advice. I think as well, they don't always know about the PSP Association website, etc. So it's signposting if it's maybe not their specialist area, that we're happy to help and advise or signpost if that's needed. Brilliant, excellent.
Well, you'll be pleased to know that's the end of your questions. No, I did great conversation. You know, as ever, every day is a learning day. I've learned something, and it's just, I think you don't often, maybe even people in clinic don't always get a chance to ask everything.
Yeah, yeah, and I think sometimes patients, you hope that you kind of give patients information that they need there and then, but then they'll maybe ask a question you think, actually, I've not covered that. Or I mean, the question about LSVT for PSP is a brilliant question.
I know, that was really important. I learned something. Not that I shouldn't, every day, as I say, is a learning day, so it's really good. That's been brilliant, Joanna. Thank you so much.
You're welcome.
And, hopefully, you know, we'll see you again on a screen soon.
Yes, indeed.
Excellent.